Please welcome Nadine Burke Harris, who's the founder and CEO of the Center for Youth Wellness.
Thank you so much, John. Can I say that was totally awesome? Did you guys practice that ahead of time?
Yeah.
That was fantastic. You're a good singer.
Thank you very much.
When I finished my residency program at Stanford, I was one of the last people in my class to get a job. Everyone felt really bad for me. But it turned out that I had actually had a couple of job offers. I was waiting for the right thing. I had turned down a couple of jobs, including one at Stanford. My Jamaican mother literally nearly had a heart attack. Nadine, Stanford faculty! I mean, that's literally exactly what she said. But I knew that I needed to be a place where I could fulfill my calling to serve underserved communities. So I came to California Pacific Medical Center in San Francisco, and I was hired to develop programs to address health disparities. So I was on the job for about 45 seconds, looking at the data before it was obvious that there was one community in San Francisco that had by far and away the highest health disparities. So, being that I was fresh out of residency and had no idea what I was doing, I wrote a business plan, and I took it to the CEO of our hospital, and I said, we need to open a clinic in Bayview Hunters Point. Now, oddly, he took me seriously, and the hospital put resources behind it, and 18 months later, the Bayview Child Health Center opened its doors. Now, for anyone who wants to open a clinic in a severely underserved neighborhood, particularly if it's a community of color, you have to understand that you can't just hang a shingle and think that people are going to march through the doors, right? You have to put in face time. So in the intervening 18 months between the time we had the business plan approved and the time we got our doors open, I went to schools and churches and after-school programs. And I said, hi, I'm Dr. Burke. We're opening a clinic in your community. Please send us your kids. And a weird thing happens when people see you actually go door to door in the housing projects. They kind of take you seriously. So when we opened our doors, they did exactly what I had asked, and they sent us their kids. Over and over again, I was being referred kids for ADHD. I was being sent kids from ministers, from principals, from teachers. And they were saying, please, Dr. Burke, please, can you look after Bobby? Bobby is falling out in class. He's hitting the kid next to him. He can't pay attention. Please, Dr. Burke, he's got ADHD. Can you put him on some Ritalin? And of course, I said, sure, absolutely. Send him over, and I will see him. But what I found was when I did my job, and I actually did a thorough history and physical, for most of the kids I was seeing, I couldn't make a diagnosis of ADHD or attention deficit hyperactivity disorder. For most kids I was seeing, it just seemed like there was something else going on. And I very recently was studying, actually this year for my pediatrics recertification board, and I came across an anecdote about Lyme disease that stuck in my head because it reminded me of where I was in that very moment. Lyme disease was discovered in 1975, right? After researchers found that unusually high rates of children were being diagnosed with juvenile rheumatoid arthritis in Lyme, Connecticut, and the surrounding towns. And so when they went in to investigate, what they found was that most of the kids that were being diagnosed lived next to wooded areas, and the highest peak of this juvenile arthritis was happening in the summer months when that coincided with deer tick season. So with further investigation, what they found was that this outbreak of juvenile arthritis that they were seeing in Lyme, Connecticut, was actually caused by this tiny spiral-shaped bacteria called Borrelia burgdorferi. Well, for me, that story reminded me very much of my situation because I was seeing unusually high rates of children who were being sent to me for supposed ADHD, but really when I looked at them, there was something that didn't quite fit. So I threw myself into the research about how early adversity affects the developing brains and bodies of children. Because what I was hearing was that these kids over and over again, stories of children who were being exposed to domestic violence, kids who were being exposed to parents who may be substance dependent or who had witnessed violence in the community. And as I was looking at this data, one day my colleague came in, he walked into my office and he says, "Dr. Burke, have you seen this?" In his hand was a copy of the Adverse Childhood Experiences study. And that day changed my clinical practice and ultimately my career. So I'm going to do a quick show of hands. How many people have heard of the Adverse Childhood Experiences study? Rocket. Or the term toxic stress. Awesome. Okay. The Adverse Childhood Experiences study is something that everyone should know about. It was done by Dr. Vince Felitti at Kaiser San Diego and Dr. Robert Onda at the CDC. And together, they asked almost 17,500 adults about their histories of what they called adverse childhood experiences. And these include physical, emotional, or sexual abuse, physical or emotional neglect, parental mental illness, substance dependence, parental incarceration, parental separation or divorce, or domestic violence. For every yes, you'd get a point on your ACE score. And then what they did was that they correlated these ACE scores against health outcomes. What they found was striking. First of all, ACEs are incredibly common. 67% of their population had at least one adverse childhood experience, and 12.6%, 1 in 8 individuals, had 4 or more of these adverse childhood experiences. And I'll tell you, they were not doing their research in Bayview. You remember I said it was Kaiser San Diego. This population was 70% Caucasian, 70% college educated. But the second thing that they found was that there was a dose-response relationship between early adversity and health outcomes. The higher your ACE score, the worse your health outcomes. If you have an ACE score of 4 or more, your relative risk of ischemic heart disease, #1 killer in the United States of America, was 220%, a little over double. If you had an ACE score of 7 or more, your relative risk of ischemic heart disease was 360%, 3.5 times that of someone with an ACE score of 0. And the difference in life expectancy was 20 years. Here we see the 10 leading causes of death in the United States of America. And being exposed to 4 or more adverse childhood experiences dramatically, not a little bit, dramatically increases the risk for 7 out of 10 of the leading causes of death in the United States. So when I saw this information, of course, you know, here I am, this little clinician running this clinic in the hood. I went to the Hospital Council, which is the group of all of the CEOs of hospitals in the Bay Area. And I got my PowerPoint, I went through my slides and I showed them. I said, okay, what are you guys gonna do about this? And they looked at me and they nodded their heads and they say, wow, you are right. This is a problem. Your data is sound. What are you gonna do about this? And I was like, that was not what I expected. So I began to kind of dive into the research about the how of how early adversity leads to disease and death. Because Just as when we understood the retroviral structure of HIV and that led to, dramatic breakthroughs, understanding the mechanism of a disease, not only which pathways are disrupted, but how, is the key to understanding how we can intervene. Now, when folks first looked at this data, the first thing they thought was, hey, you know what? This actually, all right, it's a great study, it's a large population study, but it's not that surprising. I mean, come on, you grow up in a rough household, you're more likely to drink and smoke and do all the things that are going to ruin your health. I mean, this is not really science, this is just bad behavior. But it turns out that's exactly where the science comes in. Because high doses of adversity affect the developing brain architecture of children's brains. It affects the structure and function of the way children's brains develop. And particularly, it affects areas like the nucleus accumbens, which is the pleasure and reward center of the brain that is implicated in substance dependence. It inhibits the prefrontal cortex, which is the seat of executive function and necessary for judgment and impulse control. And on MRI scans, children who have been exposed to high dose of adversity have been documented to have measurably larger amygdalas, which is the brain's fear response center. So there are real neurologic reasons why folks who have been exposed to high doses of adversity are more likely to engage in high-risk behavior. And that's important to know. But the crazy thing is even if you don't engage in any high-risk behavior, you're still more likely to develop heart disease and cancer. When you do the logistic regression to account for risk behavior, that only attenuates about 50% of the risk, right? So that's where understanding the mechanism comes in, the reason for this. How is it that adversity gets under our skin? Well, the main actor is something called the hypothalamic pituitary adrenal axis. This is your body's stress response system. And it works a little something like this, right? Imagine you're walking through the forest and you see my friend here, right? Immediately, your hypothalamus sends a signal to your pituitary, which sends a signal to your adrenal gland that says, release stress hormones, adrenaline, cortisol. And so your heart starts to pound. Your airways open up. Your pupils dilate. And you are ready to either fight that bear or run from the bear. And that's awesome if you're in a forest and there's a bear. But the problem is what happens when the bear comes home every night. And this system, which is supposed to be a once in a while kind of extreme activation, gets activated over and over and over and over and over again. And it goes from being adaptive or life-saving to maladaptive or health-damaging. Children are particularly sensitive to the impacts of high adversity because their brains and bodies are just developing. And emerging science is now demonstrating that high doses of adversity in childhood not only disrupts children's developing brains, but it also affects their emerging immune systems, hormonal systems, and even the way their DNA is read and transcribed. So when I saw this data, for me, it just blew my old training out of the water. I had to figure out what could I do? So in San Francisco, we created the Center for Youth Wellness to prevent, screen, and heal the impacts of adverse childhood experiences and toxic stress. Our model is built on 3 core pillars of clinical work, research, and field building and advocacy, all working together to transform the practice of clinical pediatrics in a way that recognizes and addresses early adversity as a root cause for life course health problems. So we started with just kind of basic screening, right? If you want to know whether a child's had an exposure, ask the question. So, we began screening all of our patients as part of their regular well child check. And in fact, believe it or not, it took us 7 years to develop a clinical screening protocol that could be literally done in 2 minutes or less, that was not disruptive to the clinic flow. And we use a de-identified screen. So our families, they actually don't have to tell us which ones of the adverse childhood experiences their child has faced, only how many, right? Because I know that if they put on that form that that number is a 4, that child, their risk of ischemic heart disease is 220%. Their lifetime risk of asthma is double. Their risk of ending up depressed is 4.5 times. Their risk of attempting to take their own life is 12 times as compared to my patient whose ACE score is 0. I know that when they're sitting in my exam room, right? And so we use a multidisciplinary treatment team that includes some of the best practices that we know right now, right? Home visiting, wellness nursing, mental health treatments, and yes, sometimes medications, as well as emerging promising practices that are demonstrated to help normalize the disrupted neuroendocrine immune system, things like mindfulness and biofeedback. We also, with our research department, do a rigorous evaluation to figure out which of these interventions work and which of them, frankly, don't. And our policy and field building team lifts those up and shout it from the rooftops, right? Because the more data that we find out about this, the more we realize that this is a widespread problem. There are now 28 states that collect data on adverse childhood experiences at the population level. And all of them demonstrate at least 50% of the population with at least one adverse childhood experience, and most demonstrate between 13 and 17% of the population with 4 or more adverse childhood experiences. This is a public health crisis. And that is kinda the good news in a way. Because for me as a clinician trying to deal with this one-on-one in clinic, it felt like it was such a challenge. But actually in the United States, if there's one thing that we're good at, it's public health. We know how to lick a public health problem. If we're talking about from lead, tobacco, HIV, AIDS, we know there's a bunch of really basic things that you have to do. Number one, it starts with raising national awareness, right? And so that's one of the things that our team has been really focused at doing. Number two, routine screening. You have to find out who is at risk. Routine screening and early intervention. That also allows us to take advantage of neuroplasticity so that when we intervene, that child's brain has the opportunity to grow in a much more healthy developmental trajectory. Then we implement best practices that we currently know of, but we also have to give the time, the effort, and the research to do the basic science, clinical, and translational research that's going to advance the frontier of medicine to address this in a really different way. We can beat this. This is treatable. But in order to be able to do that, we're going to need some leadership. We're going to need some time. We're going to need some patience. And we are going to need some courage. Because talking about abuse and neglect and adversity in childhood is a conversation that many of us are not comfortable with having. It almost seems like we'd rather be sick, right? But fortunately, I think scientific advances and, frankly, economic realities make that pathway no longer viable. This is something that with investments in a public health approach, with all of us coming together to shout it from the rooftops, to recognize we can do something different, we have the opportunity ahead of us to get to the root of the root of some of the most intractable health and public health problems our nation has faced. I believe that we have the opportunity to transform. Thank you.